No, I'm going to pass you over to Rachel to do introduction to Kate. Thank you very much.
All right, thank you all. Thank you for joining. Very excited to have our very own Dr. Kate Lyons speaking this month. She's going to give us an update on some of her work with MEN1 and hopefully talk a little bit about what we have planned as an organization as well. So without further ado, Dr. Lyons, you have the floor.
Thank you. Well, I'll start with the most exciting bit because then I'm a bit of a super sub for someone else that was supposed to be giving this talk. So I'm presenting someone else's slides. So that could get interesting. But I think, first of all, I just wanted to say that we're very excited that the Net Models meeting is happening again this year. And it's going to be piggybacking on to the NetRF Research Conference. So some emails will be coming out shortly. I'm also very pleased to say that it's being fully sponsored by a company. So hopefully there'll be some good catering. And it's basically this time going to be a one-day meeting that's research talks only. So no white paper, no discussion. Because we decided that what would be nice is that we put out a white paper every couple of years, but every year is going to be a bit excessive. For that reason, actually, the white paper from the last meeting is being delayed slightly. So that is happening. But we thought so there wasn't such a big gap that we might put it out slightly later to allow time to incorporate some of the extra developments that have happened, because there's a few publications that are kind of in the pipeline at the moment that it'd be nice to include. So that will be coming out before the Net Models meeting, which will be on the 16th of November. So that's, as I said, going to be in Boston on the day that the NetRF research conference would start. So it's standalone, but that evening then the NetRF meeting would start. So hopefully we'll start, I said, advertising that soon. Once again, it's free to attend. And will be a very similar format to the research talks before, except we're not going to have a plenary speaker or, as I said, the workshop. It's going to just be researchers getting together, maximum of 50, and we're asking for one researcher from each team. So only one would present the work of kind of their lab just to keep the numbers smaller. And hopefully it'll be a really good sort of discussion opportunity for collaboration, a free space to discuss everything without it being disseminated out sort of wider. So yes, so that's that. So eyes peeled for emails and advertising that will go round, but obviously we'd be really happy for anyone to come along and join us. And
Hey,
hopefully we'll, yeah,
is it trainee friendly again? Do
yes.
you encourage trainees to attend?
Yes, and there will be once again a prize for the best presentation by a PhD student. So again, if you're sending someone from your lab, ideally that would be a trainee or a student as opposed to the PI. Obviously, we'd like them to come too, but it would be preferable that those presentations were done by the more kind of junior researchers. We're not yet in a position where we'll take posters, but we'll see how we go for future years and how many people want to join. Because the concept is we will do this alternating meeting schedule where one year it will be in the UK or Europe potentially, and then the following year it will be in the US. And one year will be a bigger meeting, maybe 2 days with a workshop, etc. And then the following year will be just the research talks again. So that's kind of the model we're aiming for. And also, I'm sure that going forward, we'll be looking for volunteers to join sort of with the organisation and being subgroup leads, etc. But it's nice that now it's kind of a partnership between the Net Cancer Foundation and NetRF. So hopefully we'll increase our sort of impact and expertise that come with that. Anyway, so that's enough waffling really for me to fill whilst people were joining. But what the actual main point of the presentation today, so as I said, there were some clinical guys that were involved in this that were supposed to be presenting it, but it's half term in the UK. So a lot of people ended up not being available. And unfortunately, the speaker that was supposed to do it cancelled relatively last minute. So you've got me, who's going to try and fumble my way through some slides that somebody else gave me. Although I was an author on the paper, I might add. So I was involved in it, but I'm not a clinician. And these are based on the kind of clinical guidelines that came out on MEN1. and how they came about and why we think they're particularly interesting, because I know there's been a few guidelines and recommendations that have been coming out. So we thought it would be nice to kind of just explain the backstory behind this. And actually, it's nice that Heidi's here as well, because obviously they've been doing some work over in the States as well. So you'll see kind of who the authors were on this and where it stemmed from. So I'll stop stalling and hopefully share my screen with you all. Let me know if you can see that okay. I can see nodding. Okay. So as I said, these slides were actually predominantly put together by Omer and Raj Thacker, who sent me these. And what this is talking about is the multiple endocrine neoplasia MEN1 guidelines that came out in last year and how they came about. So they were based on a systematic review, meta-analysis, and the Delphi method, which I'll explain. So this is just a very brief introduction to MEN1. A lot of people here will know what that means, but generally there's 1 to 3 per 100,000 individuals that get diagnosed with the MEN1. It is defined by a combined occurrence of primary hyperparathyroidism caused by parathyroid adenomas, anterior pituitary adenomas consisting of the different subtypes that are listed there, and pancreatic neuroendocrine tumors, we'll go with, as well as the duodenal ones. And those are kind of the big three Ps that are described in this syndrome. However, anyone that knows anything to do with MEN1 will know that that's not the whole story, and there are many other tumor subtypes that are involved. And therefore, these guidelines that were being generated basically wanted to cover as many of these aspects as we could. The other thing to note is that tumours may be hormonally active or non-functioning, so either secreting hormones or not secreting hormones. And quite often they're multifocal, which means that you get multiple different tumours in the same organs. So that's kind of the background of MEN1, but then also what's the history of kind of the MEN1 guidelines? Why did this come about? Why did people think it would be interesting? So actually, the first kind of report of multiple endocrine neoplasia was in 1952, which is highlighted by this paper here that actually came from the Mayo Clinic in Rochester, of which we've got quite a few affiliations here. Then a couple of years later, sort of the genetic aspects were sort of brought to the forefront a little bit. But then there was quite a long gap. But then in 1997, the MEN1 gene was identified and was brought into sort of these guidelines and this thought process as well. And these two papers here just kind of show the work that was done there in discovering the gene. And then in 2001, there was some guidelines that were kind of the first past guidelines for MEN1 and actually included MEN2 as well. And then following that, there was another update in 2012 that was done partially by Raj and once again, Maria Luisa Brandi over in Italy. But I think what was becoming apparent is that actually things are moving fast at the moment. There's increasing information, and therefore it was kind of time for a new guideline to be generated. But the importance here was that we didn't want it just to be an opinion piece of a couple of people. There really had to be some evidence-based recommendations included in this, with some real sort of data backing up some of the decisions, which actually sometimes can be quite hard to come by. So that's kind of what went about here. And so this was actually quite a few years in the making, but then there was this whole drive to update the MEN1 guidelines. And in 2021, this started with an international writing committee and working group that was assembled. And basically, then they wanted to use what was called a Delphi method, used for questions that could not be addressed by a systematic review. So a systematic review is basically a sort of very defined way of searching existing literature, existing publications. But obviously, where that can't be done, where you can't find the hard evidence to help with your decisions, you could use this thing called the Delphi method. And basically, that is where you go around and ask a number of experts and get a kind of more consensus opinion. So what pretty much happened with this was this systematic review and then meta-analysis, so kind of publication data analysis was done. And this was predominantly focused on the 3 Ps. And what happened here was a brief literature overview. Based on this, some consensus statements developed, and then they were distributed to the experts to kind of get their opinion. This was just, say, the people that were involved in the process of analysing these. So as you can see, there's quite a spectrum of specialities that were included. So, endocrine surgery, endocrinology, genetics experts, internal medicine, even a patient was included. So then after this initial step was done, there was this Delphi sort of round that happened where basically these consensus statements were given to all these experts, and then they were asked whether they agreed, disagreed, or couldn't answer. And then the responses were compiled, and then they did a second round of sending out these statements to the same groups again to see if after some sort of modifications based on those, they were then in agreement. And if basically 80% agreed with the statement, then it was adopted, and therefore those recommendations could be seen as being basically approved by this group of experts. And then the very sort of final part of it was actually kind of to discuss the overall results and finalise these statements to be ready to be sort of publicised and included in this manuscript that was being written. But as you can see, this took actually a couple of years, which goes to show the kind of detail that was put into this to ensure that kind of the most accurate information and consensus was reached. And then the outcome of all of this was that there were 52, 3 systematic reviews and meta-analysis, the outcome that we'll go through in a minute, 52 Delphi statements, and then some additional literature-based expert opinion. And all of these are kind of now published in the papers that I'll mention as we go through this talk. So just that was kind of the brief overview, but for those that maybe know probably more than I do about how you would go about this, just a little bit more detail on the methodology. So as I've already mentioned, that these research questions focus on the 3 main MEN1 related tumours. The first question was that is less than subtotal parathyroidectomy associated with a reduced incidence of long-term hyperpara without increasing risk of persistence or recurrence compared to subtotal parathyroidectomy. Question 2 was, what is the optimal strategy for non-functioning PNETs? And question 3, do dopamine agonist resistant prolactinomas occur more frequently in patients with MEN1? So I said this was the systematic review. So these were the questions kind of at the center of this systematic review. So therefore, basically, databases were searched that, and those databases are listed there, and they were searched between December 2001 through to February 2023 to see which ones could fit into these and to help answer those questions. Included in this were randomized control trials, both prospective and retrospective cohort studies, case control studies, and case series as well. So basically, where it was possible, the outcomes were analysed through a meta-analysis using a random effects model, and the grade approach was used to evaluate the certainty of the evidence. So I said all of this is basically done in a very sort of streamlined way based on kind of a set program that you would use to ask these questions in existing literature to make sure that you're fair and incorporating all the aspects that you would want to. And basically how this is done is in the form of what is called PICO. And what this means is that within those questions that you've asked, you basically have to ask very specific things. So that includes the population. So in this case, we wanted to look at adults and children of any age with MEM1 related primary hyperparathyroidism, what the intervention is, what the comparator is. So as I said, subtotal parathyroidectomy or not. And then what the outcomes would be. So that's what the PICO stands for. So you have to define in your question which each of these each of these sections are going to be. And then, yeah, the outcomes, rates of disease, persistence and recurrence, incidence of long-term post-op hyperparathyroidism, time to disease recurrence, post-op complications. So again, this was done for each of the individual questions that was asked. So for question 2, again, adults, surgical resection, active surveillance, and again, the outcomes were centered around overall survival. And then the final one for prolactinomas, again, a very sort of similar concept. In this case, it's, adults, MEM1 related prolactinoma, dopamine agonist. There was no comparator in this case because it was just looking at dopamine agonists. And then again, sort of the different definitions of outcome. So those are the questions. And when you include all of those criteria in this very sort of set way of searching these databases, basically just over 3,000 articles were retrieved that would, in theory, cover these subject areas. And what I will just do quickly is now go through each of the results for each of those questions individually. So starting with prolactinomas, and whether dopamine agonist resistance is occurring in prolactinomas. So 10 of the studies selected through this question met the inclusion criteria, 9 uncontrolled case series and 1 cohort study. This included data on 505 patients. And this basically is showing the outcome of MEM1 patients compared to non-MEM1 patients. So failure to normalize prolactin, tumor size reduction not achieved, and patients needing surgery. And then the secondary outcomes are the then additional therapy, so radiotherapy, chemotherapy, and then another dopamine agonist required to normalize prolactin. So basically what the outcome of this was, there was no clear pattern of higher dopamine agonist resistance in MEM1 patients, and that no formal meta-analysis was possible because of the sort of lack of a pattern. And basically the grade certainty, so that just tells you how certain we are on whether the answer to this question is sort of true or false, was actually very low grade. So using the existing data in the literature actually meant that you couldn't really come to a clear sort of conclusion on that, which meant that then other methods would be used sort of going forward for additional recommendations. For question 2, this was all to do with non-functioning pancreatic nets, as I've described, and this was less than 2 centimeters. So for this one, 3 retrospective cohort studies actually met the criteria, which was from 236 patients. Overall survival and metastasis-free survival were not reported separately. So the composite outcome of death or new distant metastasis was as follows. So from the 3 different studies, this is sort of summarizing their conclusions. So if you look at surgery versus surveillance, you can see there the number of percentages that were identified and the sort of outcomes of this. So for example, also there's notes for, say, the second study, that surgery group had more tumours and metastasis at baseline, which obviously can maybe sort of slightly skew your outcome in that. And also from this study, that was highlighted that post-op complications can occur in 25% of patients. And the median time to surgery was actually 10.3 years. So what kind of were the conclusions from this? So again, a meta-analysis was not possible due to the study heterogeneity and the variability in the sort of outcome measures. So you can't get a consistent sort of statistical type data analysis. And again, the grade certainty was actually low or very low. But finally then, as I've done these sort of in a reverse order, you've got the parathyroid. And this was looking at sort of optimal index surgery for MEN1 related PHPT. So this one actually had the highest number of studies, so 16 studies incorporating 576 patients. And this is sort of indicating the summary of all this data. So you've got 73 per 1,000 having the SPTX, and then 228 per 1,000 having the less than. And what this showed was basically that the patients who had the SPTX were approximately 68% less likely to have persistent disease than the ones that had less than subtotal. So the kind of primary outcomes for disease recurrence here are also in 22 studies, and this included 971 patients. This is then 553 per 1,000 with the subtotal, and then 453 with the less than subtotal. And what this indicated was then that the subtotal was associated with 22% lower risk of recurrence compared than the less than subtotal. And then finally, primary outcome of prolonged hyperparathyroidism. This is then 21 studies with 898 patients, 100 per 1,000 with the subtotal, and then 38 with the lesser subtotal. And patients undergoing the subtotal were greater than 2.5 times more likely to experience prolonged hyperparathyroidism.
Real quick,
Oh,
Kate,
yeah.
if I may. What does prolonged, do you recall what prolonged meant in this case?
Oh, hang on. So if I go back, so I think, to be honest, I can't remember. I could make it up, but I can't remember off the top of my head what prolonged was
That makes sense.
classified as. But I can look it up and let you know in a minute.
Yeah. Yeah. So can I? Thank you.
Yeah, no worries. And then secondary outcomes. So this is all to do with postoperative complications. And this one basically, although there were 5 studies, there was insufficient data for quantitative synthesis. And then time to recurrence, there was a median time that was very similar with 4 to 13 years or 3 to 14 years. But again, there's a lot of heterogeneity and inconsistent reporting, again, meaning that the grade certainty was classified as very low. So basically, just a general summary is that for the prolactinomas, the rates of dopamine agonist resistance is similar between patients with MEN1 related and sporadic prolactinomas. That non-functioning planets of less than 2 centimeters, active surveillance does appear to be comparable to surgery with similar rates of death or metastasis, and surgery associated with significant morbidity. And then for the primary hyperparathyroidism, the SPTX was associated with decreased risk of persistent disease, decreased risk of recurrence, but an increased risk of prolonged hyperparathyroidism. So basically, due to the substantial heterogeneity and variable quality of the data, it meant that only 1.2% of studies could be included. And therefore, I think what the kind of main conclusion from this was that, and probably why in the past guidelines have kind of been more opinion pieces, is that actually there needs to be a consistency and well-designed studies to help inform future recommendations that are sort of a bit more standardized across different centres and different research groups. So actually, if you want to know the proper details of that, because as I said, a lot of this is not my area of expertise, this is now published, and this is the details of the paper that includes it. I was actually involved in the pituitary bit of this, which is why I'm less au fait with the parathyroid surgery section. But these are the kind of authors that were involved. As I said, here's the details of the publication. So it should be accessible, so you could have a look at that and read the recommendations or read the outcome of the systematic review in a bit more detail. But as I said, this systematic review kind of fed into then the design of these recommendations and guidelines for best practice. And this is kind of the core team that put these guidelines together. And this included kind of pretty much all of the aspects that we could of MEN1 and how you might want to go about that. So from, surgery, drug treatments, all the way through to genetics. And as I kind of alluded to at the beginning, is that the main aim of it was to develop a modern guideline for screening and management, but that this was done in a multidisciplinary group with a number of different experts, and where possible, based on evidence, I can't say, evidenceable data, you know what I mean, rather than just a group of people sat in a room kind of offering their opinion from maybe their centre, their country, or how things might work in their practice. So, as I said, that sort of whistle-stop tour I gave of the systematic review and meta-analysis, although actually it ended up being just a systematic review because meta-analysis wasn't really possible. So it's centered around those 3 statements which are included, but then also this Delphi method that could be used to also evidence literature-based opinion. And this was involving international experts from 22 different countries, 5 continents, to develop a consensus statement for many of the questions that remained unanswered. And this is obviously because of the complexity of MEN1. And basically the outcome of this was actually 52 statements that kind of went round everybody. And based on all of this, 55 clinical recommendations were developed to guide clinicians, patients, and stakeholders about the approaches. And importantly, this was for both MEN1 in adults and in children. So both of those are included in the guidelines. Again, I will just give you a very brief overview of what was included in these recommendations. I'll also link the paper again at the end that I've just shown you the details of. So it's quite large. It involves a lot of different information. So, but it also has some quite good tables that can be followed. So it's worth sort of looking up if you've got particular interest in one of the areas. But basically, the recommendations, so the 55 clinical recommendations that will come about, the details are kind of going to be described as we go through here. But firstly, by clinical category, so in MEN patients, including adults and children. So there was a category of diagnosis and screening. So 20 of the recommendations fell under that. 31 recommendations fell under management and treatment, and 4 of them under genetic testing. And then if you split it up by definition of MEN1 and tumour subtype, there were 4 general statements, 4, as I said, associated genetic testing, 17 related to parathyroid tumours, 15 statements relative to pancreatic nets, and 10 statements relative to pituitary adenomas, and then a further 5 that were kind of some other non-classical tumours surrounding thymic, bronchial, and thoracic nets. So this then has just pulled out a couple of those general statements just to go over. As I said, there are 55 in total. I'm not going to go through all 55, but just a couple of the sort of more prominent ones, and then also we can show you some of the flowcharts of how you could go about using some of this information. But one of the statements was that patients with MEN1 should be treated in centres of expertise with high volume, experienced multidisciplinary teams. And this then also is important to note the MEN1 diagnostic criteria. So then under this falls the clinical, familial, genetic. Most people who know or are involved in MEN1 will have heard these terms. But basically, you can be diagnosed with MEN1 based on a number of different factors. One, if it's clinical, is because you have 2 or more classical MEN1 associated tumours. So, for example, those that parathyroid, duodenum or pancreas, pituitary. Familial, so you have one of the main MEN1 associated tumours, as well as a first degree relative who is known to have an MEN1 diagnosis. And then finally, genetic. So if you have had a germline MEN1 mutation identified, even if you don't have clinical manifestations, so you can still be an asymptomatic individual, but be diagnosed with MEN1. Although just a sideline of this is that diagnosis of MEN1 may be confounded by the occurrence of phenocopies. So this is where basically other genes are either causing these tumors to occur, or you can have just coincidental occurrence of two of these. So there is basically a value in genetic testing in addition to either those things that have just been mentioned. And the sort of terminology they use, the where, when, and who. So where is the value in the clinical setting? So why would genetic testing be important? So the value is it aids in diagnostic confirmation, identifies germline mutation carriers, so you can facilitate early diagnosis and treatment, especially in additional family members. It identifies 50% of family members who do not have the MEN1 mutation. So it can also help alleviate anxiety from individuals and, again, their relatives if they can also be told that they don't carry the mutation. When should testing be done? So kind of the recommendation here was that within the first decade of life, ideally, or at clinical diagnosis, although of course there's a lot of factors to be included there, including what the patient wants. And where should the testing be performed? Well, it's very important that that will be done in an accredited department or laboratory. So it needs to be done where basically they know what they're doing, they know what to do with the results, and it can be fed back to someone that knows how to counsel and help the patients when they receive that diagnosis too. So who should be tested? So again, the recommendations here are the index case patient. So a patient with greater than 2 MEN1 associated tumours should be tested to confirm that MEN1 diagnosis if possible. Any first degree relatives of a known MEN1 germline mutation carrier, and any young patient with a tumour that you would not normally be expecting to be occurring sporadically. So, for example, PHPT younger than 30, PANETs less than 40, pituitary adenomas less than 30 years. Anyone who has multiple pancreatic nets or gastronoma at any age, anyone who has a thymic net at any age, and anyone who has sort of atypical presentation, so e.g. two non-classical tumours. So, for example, if you have a parathyroid anginal tumour, and again, that can be at any age, just to confirm whether that is MEN1 or potentially also to look at phenocopies. So kind of going back then, so that covering the genetic side, but then looking more sort of on some of the recommendations for the different tumour subtypes. So those highlighted in red will just sort of briefly be gone over. So first of all, you've got the recommendations for biochemical and radiological screening. A very important thing to note here is that this should only be done after obtaining a careful history and physical examination. So you have a real, obviously suspicion that this patient might have MEN1. And this, I won't go through all of this table, like it's basically summarized here, but this shows you the age to begin biochemical screening for the different tumor subtypes. Some of them you wouldn't at all, obviously for like a non-functioning tumor. Some they're saying like for insulinomas, which again you can see metastasizing very young, should be done potentially from the age of 5. And then for parathyroid tumors, obviously things like calcium should be measured. Fasting gastrin for gastronomas, so the hormones that you would be expect to be secreted. Age to begin screening with imaging has always been a bit of a contentious, I think, subject that's been discussed. But basically, the recommendations here, based on sort of the evidence that was presented, was indicating that for some of the tumours, it's important to start younger, so preferably around the age of 10 to 15 years, to ensure that you can detect things like metastatic disease. Whereas for other tumours, actually, it might not be as important to start as young. So, for example, the thoracic necks, you would not potentially need to start until they were in their adulthood. And then the modality of screening is generally an MRI, although obviously for the thoracic ones, it's going to be a chest CT. So then, how do you apply these in clinical scenarios? So firstly, if you have a patient with a clinical diagnosis of MEN1 or a suspicion of MEN1, if you have a first degree relative of a patient with clinical MEN1 and an MEN1 mutation or a family history suggestive of MEN1, and that family history can be both familial or genetic, an asymptomatic child of a parent with MEN1 who may have genetic MEN1. So the important thing there is they have the MEN1 mutation as well. And then a young patient with at least one MEN1 associated tumor. So then you would have suspicions that they might be occurring other ones later on. So basically, as I mentioned, there's kind of these flow charts that have been sort of designed to help sort of follow these through. So in like a clinical practice situation, it would help you sort of make those decisions. So I was just going to very quickly go over a bit of the information that's included in those. So firstly, it's, if you have patients with a clinical diagnosis of MEN1, at least 2 or the 3 main MEN1 associated tumors or suspicion of MEN1, what should you do? So test for the MEN1 mutation is kind of the first step. And then obviously you're going to take different action depending on whether they have a mutation identified. So obviously if there's no mutation identified, you would have very different outcomes to if they did have one identified. So if they don't have one, then you could just say, great, you think that they're not affected. Although it would be worth considering the occurrence of mosaicism or a phenocopy. So it might be worth looking at other genes, particularly if they're an MEN1 patient that's been diagnosed clinically, because these phenocopies do occur. If genetic testing is negative, you could perform initial evaluations similar to those for MEN1 patients. And you could consider screening and surveillance as per patient's MEN1 mutation, depending on the combination of tumors, family history, and clinical characteristics. So, of course, you still have to make the decision whether you think that's truly an MEN1 mutation negative individual or whether there could be other factors at play. Obviously, if you do identify an MEN1 mutation, then much further sort of screening and counselling, etc., is going to be required. So then you'll be going into the remit of clinical, biochemical, radiological investigations as outlined there. Also, you would want to consider identifying first-degree relatives for genetic counselling and MEN1 gene testing as well. And then again, they would go back into that, what you would do if a mutation has been identified or not. If no MEN1 mutation is identified in these relatives, then actually no further investigation is likely required because their risk is now just the same as the general population. But obviously then the outcome of the sort of clinical, biochemical, radiological evaluations needs to be considered. So if the results of those come back normal and the patient is asymptomatic, you obviously then kind of just continue to include them in the screening program. So you're looking at yearly plasma, serum calcium, abdominal MRI every 2 to 3 years, pituitary MRI every 3 to 5 years, adrenal abdominal MRI every 2 to 3 years, which would obviously come along with the pancreas ones, and then the chest CT every 3 to 5 years. And again, you basically just continue to do this until until an abnormal result is identified, and then you would proceed to further investigations. So that is just kind of an overview of how like this consensus would be about diagnosis. And as I said, that is kind of more based on the patients with the clinical diagnosis of MEN1 or the first degree relative with MEN1. There are details on the other of those in the publication, but as I said, I'm not going to go through all of them in this talk, because if you're interested, you could go back and look. But generally, just a summary of kind of everything that I've said and that is included in this paper. So once again, there's been 55 recommendations that have been included in this. These are evidence-based and have met consensus from a number of experts in different specialities in different countries that are all working with MEN1 patients in different forms. And this covers both adults and children. The one I've just shown you is adults, but there is a different flowchart for children in the publication as well. And the idea of this is it basically is an important foundation for educating and guiding clinicians, patients, and other stakeholders to improve the outcomes and health for MEN1 patients. Of course, with anything, there are limitations. So this is onto the methodology and the quality of the data. So it's primarily from retrospective series, and a lot of the evidence from specifically the systematic review was didn't have a high enough grade approach for us to have confidence. So again, a lot of this has now come back to consensus opinion based on the literature. And also what was highlighted from this actually was the unmet clinical needs. So although these recommendations could be put, there were a lot of areas where recommendations, it was much harder to deliver because there are still these very much unmet needs. One of them that I think many of us know is biomarkers for early detection of NETs, also prediction of aggressiveness and personalized risk that are obviously not involving these sort of invasive or imaging protocols that people have to go through. Also well annotated cohorts, which is really important with clinical biobanks, collaborations, etc. And then also the genetic side that we have this big challenge with variants of uncertain significance, which poses difficulties also in the diagnosis of this genetic disease, because what quite frequently can happen is you get a genetic result come back and it says it's a point mutation with unknown significance. So definitely more research needs to be gone on to really tease that apart so we can be confident whether they are or not. And then also, just to say, there was also an accompanying editorial in the Lancet Diabetes and Endocrinology along with these recommendations. But then I will stop there. And once again, this is basically all the people that were involved in this. So the main authors of the manuscript, but also the expert panel that were there to help put together all of these recommendations, and thankfully a couple of them are here, so if anyone's got any questions they might be able to also answer them probably far better than me, and I will stop there. So obviously if anyone has any questions, feel free. I can't promise I can answer them. As I said, I was presenting this on behalf of people, but otherwise please go ahead.
Unusually, I do have a question. It's on your flowcharts with the MRIs and things, is that just a given? I mean, or is that what happens obviously with the cost and things? I mean, if someone is diagnosed, that is the pathway they have to go. You don't have to fight to then get them in 2 to 3 years. Every 2 to 3 years they're going to have another MRI. That is a given that is going to happen.
Well, I think from one of the major things that came out of these recommendations was that I think they were saying where possible, you need to be going to a centre of excellence where people know what they're doing with these patients. And I think then obviously they're depending on your country, your budget, your screening programs that may differ. I think for most of the people that are involved in this consensus, if those guidelines are there and they say this is what you should be doing, it makes it easier to get those. Now, obviously, in the UK, that's far easier from, I'm sure, like Samira's here, she could probably say whether that would be a similar case. I think for most of the places in the US, it would be fine for Europe as well. Obviously, patient opinion comes in there as well. These are guidelines. It's not set in stone that you have to do this. This is a guideline for clinicians to help kind of standardize what would happen. But there are obviously going to be other factors that could influence whether you would follow that, to the letter, or whether actually there would be deviations, delays, or, problems in accessing any of this. I mean, Samira, I don't know if you want to add anything to that.
I guess I missed, I don't know why my sound shut off. Could you repeat the question? I'm happy to answer, but I heard just the last part.
I was just asking with the flowchart, whether that was a given with the MRIs every 2 to 3 years, or whether you had to, because obviously it comes down to cost. It was just whether when someone was diagnosed, whether that was what happened, or whether you had to fight to then get them another MRI and then another one in another 3 years.
Yeah, I think that's pretty much how it sounds. I guess some of other people can chime in too. I think that's really location dependent and institute dependent. For example, we don't have on-site EUS, for example. So I know many centers, especially in children, follow pancreatic lesions with ultrasound and not with CT scan or even MRIs, or mostly MRIs, and those also, stand out. So I think it's really depends on the teams, the discussion, and then every individual patient.
Okay, thank you.
But yeah, I don't know if you've heard what. Oh yeah, go on.
No, I was going to say, I mean, and we also published the MEN1 guidelines in the States with the ACE, which is the American Association of Clinical Endocrinologists. We also publish when to do screening as well. And actually, I kind of like, whenever I present what is the difference between, our guidelines in the US with ACE versus the ones that were done, with your group, it's pretty much very similar in terms of how often we do these scans. But regarding to the questions, it's also, I mean, like Kate was mentioning, it's kind of like this is our guidelines, so kind of like in order to suggestions of what clinicians can do. But at the same time, it's also patient dependent. Like, for example, we see a patient, they have a pancreas neuroendocrine tumors that were found incidentally in a patient with MEN1. We also need to understand, location. We also need to understand what is the Chi-67. We also need to understand, what is the clinical presentation of the patients that can help clinicians guide how often we do scans. It may not be 2-3 years, it may be in 6 months, it may be in 4 months, 6 months, depending on what is the clinical characteristics of the patients. Now, those guidelines mainly are done for those patients that are carriers without evidence of disease. That said, if we found disease somewhere around, like in 2 years, 3 years, then that may change the plan on how often we do the scans. And that will be patient dependent based on the clinical indications of the patients, if that makes sense.
Yeah, and I think, I mean, I said this and Heidi brilliantly just summarized it as well. I think we're saying the title of this is recommendations and guidelines. It's not, this is the workflow you must follow. And I think there's always going to be deviations that are center-based, that are patient-based, because, some patients might not want this, you and where you are in the world, and the individual has to be taken into account in this. And also the expertise of the clinicians, the services they have available. So this is kind of like the gold standard to some extent that these experts have put together, but it's not to say it's, the rule. It's a guideline. It's, something to help rather than to instruct. Perfect. Actually, I'd be interested to hear your opinion, John, as an actual sort of with your expertise in a different frame of it.
A special set of expertise or experiences. Yeah. So addressing, I guess, more directly the guidelines, and then, kind of like that I guess that workup or flow chart. I mean, it's just like what Heidi said, that once disease is detected, then folks would be, I believe, would be way more likely to follow whatever the standard is for whatever the disease is. And then what people still keep in mind as they're doing interventions is the multifocality of it. And so depending on the kind of intervention, like I think often about surgery, so you need to be more thoughtful about it, because you need to preserve tissue, because the patients are gonna, it's not unlikely that they could be having surgery again. And I think the subtotal parathyroidectomy is like, I think that, for example, that can really change things. Obviously, Samira can speak to that the best. And then in terms of pancreatic neuroendocrine tumors, which Heidi and her partners could speak to in terms of that area, it's the same deal, And then if you do a Whipple, I think that's one of the hardest parts is, someone gets recommended for a Whipple, and then of course they might already have Mets. Would you have done that the same way if you knew that they had Mets? Personally, I think is one of the most interesting questions. And so then the most important questions to ask in this population. So non-functional pancreatic neuroendocrine tumors. Now I'm just putting a plug in for what I think is important. And then biomarkers of any kind will really, really help with that. And I think that that's accessible through, a lot of different ways, blood-based biomarkers, radiological biomarkers. That's certainly something that I'm aiming to work in. And a lot of this is just coming straight from Nancy Perrier anyway.
Yeah.
And what she's talked with me about. We've been working together for like 7 years. Plus, it's just in the air, right? It's everybody's kind of converging on that as the main issue.
Yeah, I mean, I think also, as obviously my interest is more on kind of the genetic side, and I think that's always sort of an interesting topic to discuss with patients, because I think from like our perspective, it's always like, oh, you should test and you should know, and you find out all this like amazing genetic information and test all the family and all of this is done. And then actually, when you speak to the patients, it's not as clear cut as that. Not everyone wants to know all the information, and it can be quite an interesting topic. So I think that in itself is also sort of, worth consideration. So yeah.
I can speak to that if there's interest. Maybe and then please anyone else jump in. That we see that some family members are into it and want to know. Some family members don't want to know anything. They, in some sense, are just ready for screening. Maybe they'll never be ready for screening. And then, of course, there's access to care that can make a big difference, because it's not always easy to go to NIH or MD Anderson, Mayo, Cleveland Clinic, all these areas, right? So that's what I can speak to the most is in the United States, obviously. So I think we see a range of what people end up actually sort of like being able to get, balancing between what they think is best for them and what they can actually do. They have families, they work. I mean, it's like everything else. And then I'll toss out one more thing, and then I'll stop. Is that I've forgotten it. Of course, what we really want is more of a preventative method, right? So that we don't have growing neoplasms. I mean, this paper just basically outlined watch and wait, right? Which is, nothing, if you will, nothing against that. That gets people a long, long way and is very, very important. But what we want as the next advance, of course, is to move beyond watch and wait and know when someone needs an intervention before it's a problem. Can we prevent it? And I know some studies have looked at that, maybe with some somatostatin analogs, if I'm recalling correctly. And so then, Kate, you made me think of that. Like, is there some way to change I'm just speaking like crazy, right? But, is there some way to change the histone, the epigenetic changes so that it's a little bit healthier and maybe it never gets to that state, so we can stop them as just neoplasms instead of malignant neoplasms? Let's do that.
We're trying.
Yeah,
I think there's many of us trying.
You know where I am, right? But I know where you are. I'm not saying that. Yeah, we all will just keep working towards that. That's I think the best solution, of course, other than some kind of genetic therapy.
Well, I think all of us will say that this disease is chronically understudied.
Yeah.
And the gene itself is chronically understudied. And I think, obviously, we're preaching to the converted here, but I think between us all, that's something we really want to improve. And obviously with the Net Models hat on as well, the fact that there still aren't very good models for MEM1 is kind of ridiculous, considering, we've got mice models that have MEM1 mutations that don't even recapitulate the human disease properly. And none of the cell lines really that have been used for years have had it. And no one seemed to mind that we've just, like that no one's really had a concerted effort to put these things together. Seems kind of strange, which obviously there's brilliant people working on that now. And there's some really exciting stuff to come. And then hopefully that then super accelerates those concepts, which means that we can start doing that. But at the moment, it's really difficult to try these therapies, try these mad ideas, look at the biology, because we don't really have the toolkit from the early sort of discovery science phase to actually do it. We're getting there. And I'm sure the next few years, decades will bring some very exciting things.
Years.
But,
Come on, years.
But then, well, we'll see. We'll see. We're trying. Yeah. If someone will give us money, we'll do our best.
We'll get money.
We're all trying.
We'll get money. I think it's not even money. I mean, it's not about the money. We will work as a community to come together on this thing that we all overlap on, this really important value, this really important group of patients, as well as this really important sort of gene and disease that we can learn a lot about from. So it's not, as you know, I'm sorry, now I'm really going. It's not just about money, of course. It's about, continuing to trade samples, continuing to share knowledge, continuing to give your time, right? Your expertise. That's so valuable. That's worth gold. And with that will come more and more resources that will include funding when it's appropriate. But when we're looking at our partnerships, let's keep building those really authentic, long-term partnerships that will last the decades, so that, hopefully in a few years, we'll have some more stuff done. So then a few more years after that, we'll really be developing these therapeutics. And I know that that's what this group is doing. That's why it was founded. That's what the Net Modeling meeting is about. And I just see that over and over again in the community. And, we will be able to get this to other people that include those who are interested in this at the funding level as well.
Yeah.
So couldn't be more excited.
I have kind of a random thought. Oh, go ahead.
No, I was going to say I completely agree with you, John, about what you just say. Yeah, completely agree.
Yeah.
And we definitely need to work together, share information, and find better ways to, understand disease biology as well. And I understand about the models. I mean, that's been an issue for everyone. But at the same time, we also understand that, these are very slow growing as well. Even people that has been trying to develop these models are relatively very slow growing. And can we find another way, a different way to, also understand disease biology or mechanistic disease biology of these tumors, so that way we can better understand. But I mean, I agree on everything that you're saying, Kate and John. I mean, this is very important. Yeah.
Okay, Rachel?
Yeah, no.
Random thought?
I was just gonna, agree with John and, keep pushing and, like Heidi said, understand the mechanism and the biology of MEN1 and, even taking that knowledge, what we learn from MEN1 driven tumors, applying that, to sporadic ones. And sometimes I feel like there's a divide between, oh, that's MEN1 and this is not MEN1. They're, separate, which they are separate, but I think we can learn from the different tumors, and just better understanding the disease mechanism and the biology will drive the whole field forward.
We just don't know what the differences are between sporadic
and
PNATs. I had that discussion. I was able to attend the AES meeting. I had that discussion with several people. I don't need to name drop, right? But these are, folks who really know what they're doing, and we just don't know. That's a really interesting line of research. And I'm really excited about human studies, right? And I think that's something that we'll be able to accomplish more at the clinic too. And MD Anderson already has and NIH have really great stuff. So I'll work on that end.
I think this is great. I think we're saying it's a partnership. We need to understand, menin is everywhere. We're doing studies in Drosophila, and it is expressed from the earliest stage of development you can come across. So it's hugely important in all these different things. And yet no one really still knows what its function is properly. And I think if you team that with the patient studies, you've got some really powerful work that can come out. But we're not all experts in all of it. So hopefully we can all work together in our own little areas to bring together and really start doing some exciting
I have an ignorant question, Kate, John. Is MEN1 knockout embryonically lethal?
Yeah. Well, it depends what you're looking at, but yes.
In some cases, okay.
In every animal I've ever looked in, yes. But not in patients, because obviously we wouldn't see. But you don't tend to get homozygous loss being
Right.
viable. Obviously, you
Yeah.
can have mutations that might not be like a complete loss, but if you have a complete loss of function, so that comes from the mouse work. If you look at flies, mice,
Yeah.
I think someone did a zebrafish too, because it's so, that's what we were saying, like it's so, if you look at the flies that we're doing, from literally the first stage you can physically look at, it's expressed.
It's fascinating.
Yeah.
Okay. I hate to round this up because it's been great, but we've really overrun. I love all the enthusiasm. It's fantastic. So thank you so much, Kate, for stepping in for us. Really interesting. And yeah, go John.
Thank you, John.
Well, go us all, right? Everybody.
Everybody. So anyway, yeah, so thank you very much everyone for coming. And next meeting is 25th of June. And yeah, so I hope to see you all there. So thank you very much again. And obviously this recording will be on our YouTube, hopefully by tomorrow. So please share it with anyone else, and encourage your colleagues to come next month. So thank you very much. And I will see you next month.
That's
Thank
great.
you.
Thank you.
Thanks.
Bye.
Bye.
Bye.